Not only is it not good for the person, it's not good for the jail or the prison. I mean, they end up becoming your highest problem prisoners. I mean, obviously they're acting out in prison like they were acting out on the street. You know, ideally to have voluntary compliance with treatment orders would be great, but unfortunately, and which was what a lot of advocates who are in opposition to my position play down and call it coerced when you do AOT. Well, coercion is not high on the list of these people. They're looking for where they're going to get their next meal, where they're sleeping that night, and AOT, or assisted outpatient treatment, court ordered. Once they're back in care, back in treatment, their personality changes. They're back members of society. They're usually not violent. They're not issues at all. They then revert into that larger group of mentally ill people who are not an issue. In these national cases, I mean, I look at, like, Loeffner's a perfect example with the Gabriel Gifford shooting. College said, listen, you're not coming back to school until you have a letter from your psychiatrist saying you're safe. They were that concerned about him that he felt he was dangerous. However, there was nothing in place for anyone to know that other than the school and Loeffner. It might have been different. I mean, had he been involved in a court-ordered assisted outpatient treatment, I believe in his case he met the criteria that he could have been had things happened. And I think that's the case with a lot of these active shooters. The Navy Yard incident, I mean, I could go on and on, Virginia Tech, they're all long histories of severe untreated mental illness that end up in tragedies. And they're all cases where people knew ahead of time that this person is potentially a problem. It's not your... There are not that many people that fit that criteria, and the sad part is they could have been helped also. I mean, their life is not in very good condition prior to these incidences, where had they been in care and in treatment, I think we could have avoided a lot of these incidents. If you look at Kendra's law right now in New York State, actively in Kendra's law, which is our assisted outpatient treatment law, there are about 2,000 persons in a state that has a 20 million population. So if you carry that out, it's like 0.0001% of the general population that would fall under Kendra's law. It's an extremely small amount, but in order to be included in a program such as court-ordered assisted outpatient treatment, you have to meet a very high standard, or a very high bar of what we have just spoken about: repeated hospitalizations in a short period of time, past history of violence, non-compliance with medication. So it's a readily identifiable subset of the mentally ill community that we know who it is. We know who those people are for the most part. Most states now have a law similar to Kendra's law. New York State's Kendra's law, which was enacted in '99, was used as boilerplate for most of the laws that exist now from state to state. The problem is that they're tweaked as they go from one area to the other area. New York State law, contrary to popular belief, does not require all the time dangerousness, but it's interpreted that way. Some laws require dangerousness, which is bizarre because it's the only law I know of that requires dangerousness before action can be taken. Normally you would think that a law would try to prevent dangerousness, and in this case these laws require dangerousness. Some states have written their law to include, which I think is a great idea, need for care statute rather than dangerousness. So when the police officer, such as in New York, responds to a family's house and there's a 17-year-old, 19-year-old banging his head against the wall saying, you know, the FBI put a bug in my brain, and the officer says, well, do you want to hurt yourself? No. Do you want to hurt somebody else? No. And then he says, well, there's not much I can do for the family, and leaves. I mean, that's a bad situation that a police officer's not happy about either. So in a case like that, when you see that the person is obviously in need of psychiatric care, there should be things in place that we can act at that point and get that person to a psychiatric evaluation point in a hospital to determine whether further care is needed. If they're in a program such as assisted outpatient treatment where the court orders that that person take their medication as a condition of remaining in the public, and they assign a caseworker, an intensive case manager, to check on that person weekly, and depending on how bad the situation is, whenever he feels necessary, to check on that person to make sure that they're complying with their treatment. When they do that, studies are overwhelmingly showing fewer arrests, fewer reincarcerations, fewer hospitalizations, fewer assaults, fewer. So I mean, the argument against AOT from a political standpoint is, well, what about the cost involved in having them checked on? Well, the cost involved in checking on them, it has to be, and a lot of studies show, extremely cheaper than hospitalization, extremely cheaper than putting them in jail and prisons, and I mean, it's just can't compare. But again, it's Office of Mental Health, when they're in hospitals, it comes out of their budget. When they're in jails or the police are dealing with it, it comes out of criminal justice budget. So people have to stop looking at whose pocket it's coming out of and what the sum is in total, not where it's coming from. And I think we'd save money. Yeah, we worked very closely with the governor's office on the mental health sections of Kendra's law through the SAFE Act. And specifically, we worked with the mental health changes. There were loopholes that needed to be tightened. Some of them were accepted, some of them were not. Some came right from my thesis that you're familiar with. And a few that I think that are very important, one of the suggestions was that persons in prisons and jails, upon release, be evaluated for inclusion into assisted outpatient treatment programs. Now, the reasoning behind that was, you could be in prison or in jail for a year, and while you're there, you're receiving your medication because you're in jail and the jail's providing it. Suddenly, your time is, you've served your sentence and the door is opened and out you go, and that stops your care. So and then you are again a danger to community, possibly, or you're going to end up back in again, because once you decompensate from not taking your medication, you're in the same condition you were there that put you there in the first place. So that, I think, was big. That was included as it relates to prisons. It was not included as it relates to county jails, and the reasoning behind that was to include it for county jails would be considered an unfunded mandate and would have to be done. However, the state did include it for prisons because the state foots the bill for the prisons. My concern with that is that our problem is probably more prevalent at a county jail level than it is a prison level, because most of these people are arrested for minor petty offenses. Prior to the inclusion in SAFE Act of changes to Kendra's law, the assisted outpatient treatment order only extended to the county line. So if a person lived on one side of the street in, say, Orange County and moved across the street into Rockland County, there was no provision in the law that person's AOT file be transferred from Orange to Rockland. It may have happened, but there was no provision in the law for that to happen. So technically, you could have a person deemed by a court to be dangerous when not in care on one side of the street, move to the other side of the street, and no longer be covered under Kendra's law. So that's now changed to include transportation of the order from county to county. Most people understand that the police officer has a split second to make a decision. It's a person with a knife, it's a person with a gun, it's who's coming at you, and what their mental condition is at the time is pretty much irrelevant when you're considered or concerned about your own life. However, what we're trying to do now, I mean, I'm a fan of CIT program, the Memphis model, crisis intervention teams, which we're trying now to put together a committee to push for funding to expand CIT training in New York State with police officers throughout the state, to try and reduce the frequencies that these shootings happen. It's proven to be very effective in responding to emotionally disturbed persons. It marries the police officer with the county's mental health departments and their outreach teams and the hospital personnel. So it makes this a systematic approach to dealing with the severe mental ill issue, rather than the police by themselves picking them up, dropping them at the hospital make a determination and dropping them back off. I mean, it becomes, I see it as all three organizations taking ownership of the problem and working together to try and see how it can be resolved. But I think that needs to be combined with the understanding that more hospital room is needed for these psychiatric cases. By having CIT and having qualified people there to see the person while they're in crisis at the scene, I think we'll hopefully get away from the dangerousness criteria and more towards the need for care criteria. Because I tell these people all the time, some of the most seriously mentally ill people are mentally ill, they're not stupid. They've been through this, especially what we call the frequent flyers, who've been through this many times. They've been to the emergency room many times. They know what to say and what not to say to avoid being kept at the hospital, which they don't want to be. So they know that if they say, yes, I feel like killing someone or I feel like taking my own life, that's a ticket for them to be there at least 72 hours. So by the time the police have calmed them at the situation scene, transport them to the hospital, they're in a different state of mind, they're calmed down, they talk to the doctor, and the doctor says, well, they don't seem too bad to me, they seem fine. So hopefully the CIT and embedding a crisis response team with the law enforcement that are going to the scene, a more accurate picture of what's going on with this person can be relayed when they arrive at the hospital. So, and because most of the police that I deal with, I say they're sick of what they call the revolving door, or some refer to it as the catch and release program, where you're struggling with these people. You get in the hospital, the doctor says, well, they don't want to kill themselves, they don't want to kill anybody else. I mean, I've had doctors who don't agree with that section either, and say it should be need for care, and they tell me that many of their emergency room physicians that make these decisions determine dangerous to self or other to be immediately in the process of killing themselves while they're being interviewed, or immediately in the process of killing the doctor while they're being assessed. So I mean, that's how crazy it can get. So yeah, it's a huge consumer of law enforcement resources.